you deal a lot with the new HIV infections. We had this conversation some time back in the Citizen Studios. This concerns you quite a bit. Take us through some of the challenges that your organization is going through, Mombasa County is going through in addressing the drug addiction menace among the youth here.
Thank you, Victoria. I think the burden of drug, alcohol and substance abuse in this country has reached levels that you can actually say it's a disaster, and especially among young people. And in the HIV response globally, we know that injecting drugs practices contribute to almost 28 times HIV cases as compared to people who do not inject drugs. And here in Kenya, the prevalence of HIV among people who inject drugs is 4 to 5 times higher than the general population. So where we have an average of 4.3% prevalence among general population of HIV, it's about 18.7% for people who inject drugs. And one major challenge we faced in managing HIV among people who use drugs is firstly how to prevent HIV in the first place. And what we have seen just this week is a growth in the practice. And we have witnessed the age, of course, lowering of the young people who are using drugs. But most importantly is also on the positive side, we have seen that the interventions have begin to show some results. And one of the major challenge of managing HIV among people who use drug is actually to even make them adhere to treatment in the first place when they are infected. Secondly, we have witnessed what happens when the social fabric breaks down, because by the time somebody is injecting drugs, they most likely have been homeless, they have been chased away from their homes. And what we saw during this week is a classical example of where some of them living with HIV did not even have a place to store their own medication. And we visited the den, we met the women, we met the young men, and it's really looking at the situation of what we do in managing HIV among a population that we know that the disorder is something that they're not able to control by themselves, has triggered us as an institution to work with NACADA here and begin to say that it's an issue that we first now deal with the drug issue at the same time as we address HIV. So, and it's not just HIV, it's also hepatitis C. And it's not just also hepatitis C, it's a prevalence of tuberculosis. So all these factors begin to play in a synergistic way. And coupled with the fact that the people are homeless, the people are desperate, they need treatment, and the services that are available right now are not even adequate to treat everybody. We have about 26,613 estimated number of people who inject drugs in Kenya. And the number of rehabilitation centers are not really enough, and where they are also costly. So we have a really different set of challenge on how we then manage HIV in such a unique condition.
Prof, let me come to you and let's talk big picture in terms of the magnitude of drug and alcohol abuse in this country. We heard Dr. Masha talk about roughly 26,000 drug users in this country. But when you look at the bigger picture, what burden does Mombasa hold, the coast region, and why is it such a factor when it comes to drug abuse?
Thank you. Maybe I can talk about generally in the country. We have several drugs. Alcohol is a drug, although it's usually overlooked, but it's one of the most abused drugs. Then we have other drugs, you know, like heroin, cocaine. those are classified as hard drugs. But we also have cat, the miraa, still those are drugs, tobacco, you know. So we have quite a number of those kinds of drugs. For Mombasa, the situation is worse because of the hard drugs, the heroin, the cocaine. Of course, when we look at generally some drugs like alcohol, we find some regions like Western are leading. Western, Nyanza, Nairobi, Central. Coast, as far as alcohol is concerned, is not so much. Coast and Eastern and some regions. But the challenge we have with coast is the hard drugs. That is where the problem is.
So why are the hard drugs such a factor? Is it because Mombasa has been seen as a drug trafficking hub?
You know, initially, the cocaines and the heroins, Kenya used to be a transit country, you know, where drugs going to countries like America, Europe, and so on, were passing through Kenya just as transit. But now a scenario has emerged where Kenya is now a destination. I mean, it's become a market now, you know, and now that is where you find now the leakage coming in. Drugs come in, they are not going out, you know, they are being used, you know, by our people. And I think that is where, and you see the first point is either Mombasa or the airports, and therefore Mombasa is an entry point because, of course, of the open seas and you know the kind of seashore we have, you know, the coast. Yeah.
Right, Taib, you've been at the forefront of this fight for a long time. You know, take us through the trend you've noticed over the years and how bad it has gotten today.
Yeah, thank you very much. I think a good question in terms of the user destination, because this has been a transit destination for many years. And of course, because of the porous borders that we're having, the entry point from the ocean, that the drug is coming in. If you view the picture within 20 or 10 years, you'll find that growing problem in terms of drug use, that the hard drugs that we talk here, that is heroin, which is easier to and readily available within the coastal region, especially Mombasa. And when you reflect on the steps or the measures that have been able to be put in place, doesn't reflect to the number of people that are there. So this has been like a growing effect in terms of the number, in terms of the people, and also the challenges, because when you look back, there was no rehabilitation in the coastal region. We only had one, and this was a very big problem. Now we have few of them that are within the coastal region, but what has been alluded here is also the cost of it that has been. So when you look into the issues of drug and substance abuse, it involves a lot of efforts that needs to be put together. Of course, one is the outreach needs to be embarked with support and resources that we really need to look into and reach to people and engage them. And that has been our core work in terms of reaching out and engaging people. And we know the model that has worked very well within our country is the harm reduction model, where you reach to people where they are, give them empowerment, encourage them, and give them an opportunity to be able to choose the option of treatment that can be able to go into and have that. Key important also as we reflect back is the family involvement within all these issues. We have really talked about the people, the situation of drug issue, but where do we involve the family? At what level do we bring in the family? So over the past experience we have seen, if you haven't gotten very good upbringing, the proper guidance, you'll be able to be hooked into drugs, then you will be left alone. The family will leave you in the street. You will be able to now to just use to live and live to use. That is the situation that you find yourself. But we need to involve and bring in the family and see within this component of harm reduction and bringing people closer and giving them options, because you cannot say all of them will need rehabilitation. They will need rehabilitation, some will need a medically assisted therapy, some will need spiritual support, some will need proper guidance from family, and they'll be back to their normal situation.
Mohammed, let's talk about what the county is doing, because, you know, Taib was talking about this harm reduction approach that's been used and has been quite effective. But when you think about how many therapy clinics actually exist in the county, not enough to deal with the burden. Just paint a picture of what that burden looks like and how to close that gap.
Thank you, Vicky. The county government has been key in terms of offering interventions targeting the people who use drugs, especially the hard drugs. And one key thing that we boast as the Department of Health is having leadership that is key and is focusing towards the eradication. It's very supportive in the interventions that are there from the Governor, Honorable Abdul Swamad. It's very supportive. Statistically, we have around 3,500 people who inject drug, and out of that, those who use drug are about 10,000 hard drugs. Currently, the county has interventions through the MAT clinic. MAT basically means medically assisted therapy, whereby the intervention is the use of a drug called methadone to be able to get this person out of using heroin. And about 2,000 clients out of the number have been enrolled in the program. So we still have a gap. Those that are injecting, we still need to reach to about 1,500. And those that use smoke or sniff or something, we still have a huge load that we need to reach them. The intervention that as a county we have is basically we are targeting them through the MAT clinic, whereby we are using the harm reduction approach. Okay. MAT being the core component, but we also have other components that we target these people who use drugs. Amongst them, key thing that face these people who use drugs are the comorbidities, the diseases that come while they use these drugs. Key amongst it is HIV. The prevalence, you have been told, it's 4 to 5 times higher. And that is one key thing. Apart from using methadone, we also target them with HIV care and treatment, those who are positive. We target them with the routine HIV testing, basically on a quarterly basis. Yeah. We also target them with the care and treatment, whether within the site or link them to other sites. We target them with the treatment for TB. Majority of them, they live in dens. In dens, they live in a congested environment, in a dirty environment. So TB spread is so high. So we target them with the treatment of TB. And this, to a majority of them, we offer by use of DOT. DOT is direct observed therapy. Okay. Daily dose, daily tablet issued to them at the MAT clinic. We equally target them amongst the package with psychotherapy, that is psychoeducation, counseling, family therapy, working closely with other partners and closely with the CSOs, TIBE and other CSOs, to ensure that apart from taking the methadone and getting the clinical assessment and clinical medication, we also reintegrate them back to their families and back to their nuclear family. It is also extended to work-related, if this someone messed around because of the addiction. So those are the interventions that we offer to the addict. One key thing as a county, Mombasa County, that has been brought on board is the aspect of a policy document that was released late last year called the Sustainable Harm Reduction Business Plan. As we treat these drug users, the gap is the livelihood support. The gap is where will this person go after the treatment. A majority of them, like it has been said in the statistic, start the use of these hard drugs at a very young age, 11, 13 years. So this person will not have a skill set to be engaged in formal employment. So the Sustainable Harm Reduction Business Plan, it is a policy document that was brought on board that engaged the PPP approach, public-private partnership, it engaged the business sector within Mombasa County, whereby those people who have been rehabilitated and they are doing okay will be linked to either attachment, internship, and job opportunities through the different identified business sector and the private sector. So this is one key thing that the document has been launched. With the incoming of the new governor. We will now be disseminating and following it up to ensure that it is implemented within the county.
Okay.
Lastly, one key thing that the county is doing is ensuring that it leads from the front by ensuring that there's collaboration with all the partners that are working in that sector, be it the government departments, NSDCC, NACADA, NASCOP, other partners that are supporting other NGOs and CSOs, by ensuring that on a quarterly basis, there's a technical working group that is sitting to discuss the issues relating to drug and substance abuse, look at gaps that have been identified, and mitigate what is the way forward to ensure that these people are being assisted.
Dr. Masha, let me bring you in there because do you feel the harm reduction approach is effective enough to reach as many people who need the help as possible? Because this is on a voluntary basis, right? You're counting on these individuals to come for the treatment, to come for the medication, and to be consistent. So when it comes to HIV, for instance, do you feel that is effective enough?
Thank you, Victoria. So that is the Kenya AIDS Strategic Framework policy framework is designed around, of course, the prevention aspect.
Yeah.
So how the harm reduction program is designed is that we don't wait for people to come because, and Taib will tell you, the first thing we do, of course, is to go to them and offer some form of relationship. And the first relationship is actually to give them those injections that we give them a kit. And we say that we are here to reduce the harm that you're doing to yourself. And so, Victoria, if you were here many years ago, maybe before 2015, when you met somebody who is actively using drugs, they would be having abscess and wounds on their hands. In fact, most of them would have a paper, the nylon papers wrapped on their hands, and some would be having septic wounds. So the first thing then we did was to say then, how do we reach out to these people? Yeah. So the harm reduction starts by what Taib and the community organization do. They meet them there, they start discussing, they offer the first step of, we love you. We know this is a mental disorder, so we begin treating the smaller issue we have, and that's why the HIV prevention starts. So that we don't get the infection in the first place. So where the HIV is highly infectious is when there is the absence of a clean needle. And they will tell you what they call a roster. Is it a roster? They want to use the drug now. And if the injection is not there, a safe needle is not there, they use anything. And one of the things they do is to pick up the used one. In addition to that, there has been an element which they sometimes were because the drug is very expensive. Heroin is expensive. You'll be told here, today we are being told the price has actually gone up. A small dose like this of a nail is about 300 shillings. And you need about 10 doses. You're being told 10 doses, that is about between 2,000 to 3,000 shillings.
To get high.
To get high. And so if you don't have it, then sometimes they would then borrow each other blood and mix, use it to mix or to also substitute the one who is high to offer the other one the dosage. So with that, that's where HIV comes in, the sharing of the needles. So the first thing of the harm reduction program is to look at that aspect. How do we stop this infection? Then there's also another aspect that we must discuss, especially when we talk about young people. We used to hear about what we call chemsex outside there. When it's not hard drugs that you're talking about, where we've heard of groups of young people getting themselves into a room and using drugs, abusing drugs, and using them to probably have sexual practices. So we are looking at all those aspects and seeing how do we prevent HIV in the first place? So for people who inject drugs, if we can be able to give the education for prevention of drug use itself, it's an entry point for us. But then you asked a question, is it enough? Do we see that we are doing enough to stop new HIV infections among this group? And I think the county government has said the investment in this area has been very minimal in terms of the growing need and the money we're putting in place. For a long time, this program has been externally funded. Yeah. And we have recently woken up to realize that it's a bigger problem, and the fact that external resources are shrinking and the demand is there, we need to work on both the prevention but also to see where we can get additional resources. And that's why you're hearing the county saying, can we work with the private sector, because the danger of relapse of somebody even who has gone through the treatment program is very, very high. Today we had most of them, like the women I was talking to, and they were saying that I had come for the program, but then my partner has been arrested, he's in prison, so I'm back to the habit. So the issue of sustained livelihoods after you've given the treatment is a major challenge. And that is where also, for HIV program, it's still a major challenge, because then we keep having that cyclic approach where we think we have done it, and then only to realize that the aftercare model is not there and is absent, and it then creates the gap in the HIV management and prevention.
We'll talk more about the treatment approach, but let's take a short break as we continue on with this discussion. We'll also reach out to our audience members to get their thoughts on this particular conversation. Stay with us. We'll be back.